Muscular dystrophy. We heard much about the Duchenne muscular dystrophy, DMD. There is one Baker type of muscular dystrophy. It's also possible and a little bit possible common, and there are a few more other muscular dystrophies. By far, the commonest is DMD and BMD. So DMD is usually Duchenne is usually X-linked recessive. 30% cases you have new mutations de novo, and the mother is carrier because it is an X-linked disease, and no muscle weakness at birth except in the mother who has a little bit of different difficult mutations, unfavorable immunization, what we call X-linked. Other X is healthy, or in the when the defective X is immunized, the healthy X is immunized, you have a little bit mother maternal symptoms in 8% of cases. Usually they do not, they are the carriers. So they carry the dystrophic protein, which helps in the sarcolemmal disruption. Thereby calcium influx takes place and myofibrils are broken down, proteases are accessed, and myofiber degeneration giving rise to the fibrosis. There is also a little bit of regeneration, but that is a futile attempt, and ultimately what we get, non-contractile muscles and hypertrophic muscles. More common in children, your 2 to 5 years, 50% maybe at 10 years, and there is gross motor delay. There may be skill defect. Child walks normally, but at the 2 years or so, he has limb girdle sort of weakness and lordotic posture, and your difficulty in climbing upstairs, and ultimately what do you see? The calf muscles are hypertrophied, which you call pseudo hypertrophy, and there is wasting of the thigh muscles, tongue and forearm muscles may be a little bit of hypertrophied, and ultimately there is some amount of weakness. Gaussian is positive. So when someone is asked to stand from the sleeping posture, supine posture, he does different maneuver. He pulls his hand and push it to your back thigh, and then he crawls he climbs in his upper limb. So this is Gaussian. It is diagnostic clinically of the DMD, Duchenne muscular dystrophy. And apart from that, you have waddling gait. You call it Trendelenburg sign. You have facial muscle weakness. You have later on transverse and horizontal smile, like something in the face because of the facial myopathy, and at times you have language difficulties. You have difficulty in expression, dysarthria. The child might have frequent fall and the toe walking, trouble running, and difficult upstairing. So at 10 years or so, some improvement may be there, but at the end of the journey, 20 years or second decade something, the child is ultimately crippled, and at times bed bound, homebound something, and ambulation may not be possible, and death over here is usually due to the respiratory muscle paralysis, pneumonia, and your snoring is possible in these children, sleep apnea, and your aspiration, regurgitation, they are common, and airway, nasal quality of voice, nasal tonation, they are possible. If you investigate this child, you will have the muscle enzymes, CPK, aldolase, they will be higher. You might have the transaminase elevation, AST and ALT, and cardiac involvement gives rise to the arrhythmia and your myofibrosis. If you do echocardiography, you might get the cardiomyopathy, and there can be features of the heart failure. So death is around 20 years or so, good amount of patients. Treatment is very unsatisfactory till date. Your people are trying with some of the newer drugs. Ataluren, there is some nonsense suppressive therapy, they call it. They are approved by the European Medicinal Association, and ETP exon skipping sort of therapy also approved by the FDA. People are trying, people are thinking about gene therapy.